It's been nearly 4 years since the Martinez administration stopped Medicaid payments to 15 nonprofits that provided behavioral health services, accusing them of millions of dollars in fraud. The organizations were eventually cleared of wrongdoing by the Attorney General, but many had already gone out of business. The administration brought in 5 providers from Arizona, as you might recall, but only one of those companies is still here. So what is the state of mental health care in New Mexico? In the first of a 4-part series, correspondent Megan Kamerick looks at where the needs are across the state.
I'm joined by Democratic State Senator Jerry Ortiz-Pino, Maggie McCowan, Executive Director of the New Mexico Behavioral Health Providers Association, Elise Padilla, a fellow with the National Latino Behavioral Health Association, and Natalie Smith, therapist and Executive Director of Awake and Aware. Thank you all for joining us here. Jerry, you're chairman of the Legislative Health and Human Services Committee, and you hold interim committee hearings around the state. What have you been hearing the last few years from people in communities around New Mexico about accessing mental health services?
Yes. Actually, I was chairman. This year, it revolves back to a House member will be chair.
Ah, okay.
We alternate every 2 years, but for the last 2 years, I have been chair. And we hold hearings. Last year we held them, or 2 years ago we held them in the southern half of the state. We were in Las Cruces and Ruidoso and Roswell and actually Silver City as well. And then this past year, in 2016, we were in Las Vegas, Taos, and Farmington, the northern part of the state. Curious, in each instance we held hearings asking local people to share with us what their experience had been under this changed behavioral health system. Mm-hmm. Changed in a number of ways. Now we have the integration of primary care and behavioral health. We have all the HMOs providing behavioral health, not carved out to one, and changed in that many of the providers have been ruled ineligible to participate in Medicaid, so huge gap in services. And in every community, the response from probation officers, judges, child welfare workers, and community people was, we don't have the services we used to have. Mm-hmm. We used to have this counseling program or this alcohol treatment program or this residential group home. And they're not there anymore. Where are we supposed to find these resources? Mm-hmm. So it was, it's all anecdotes. It's all people's experience, firsthand experience. But there was not one community where we went to that people said, gosh, it's so much better than it used to be.
Mm-hmm. And yet we're hearing from the Human Services Department, and they quoted a recent report by Mental Health America, that our rankings have improved dramatically in terms of access for folks who need it. Do you sense where there might be a disconnect between these two opposing facts and from what you hear from constituents?
Yeah, I do, and I think I've been giving this a lot of thought because all last summer we pulled in Dr. Lindstrom, the head of the Behavioral Health Division, and asked him about
HSD.
At Human Services. How could your numbers be so robust when the firsthand experience of people in the community is there's nothing out there to provide treatment? And I think what it boils down to is we're talking about 2 kinds of behavioral health. And correct me, you all that are firsthand involved in this, I may oversimplify here, but it seems to me that we have those people who have been depressed, feeling anxious. They go in to see their primary care doctor and he prescribes an antidepressant or he prescribes a medicine to help them sleep better, and he bills that off to the behavioral health part of his contract. So the numbers are growing, but those aren't people that were ever seen in the behavioral health system previously. They were people who were seen in the primary care system. They were getting prescriptions before, but that doctor didn't have a contract to do behavioral health. So those numbers weren't reflected in what we had before was a system that dealt with the seriously emotionally disabled, the ones that were walking on the street talking to themselves, or who were undergoing schizophrenic breaks, the ones who were contemplating suicide, the ones who were so depressed they couldn't get out of bed in the morning. And there were programs that had been working with them for many years. Those are the programs, I think, by and large, that got wiped out, and those are the people that are now either, I think, being seen, if they're seen at all, in jail, or in the homeless shelters, but not in the primary care system, which is how we're providing behavioral health.
We have a link to that Mental Health America study on our website, and I believe one of the things they say about their data is they don't include people who are incarcerated.
Yeah.
Or people who are homeless who aren't in a shelter. So there could be a lot of people missing in that data. At least, Padilla, our Medicaid expansion under the Affordable Care Act has helped reduce the number of uninsured in New Mexico. But Bernalillo County passed a special tax a few years ago to fund more behavioral health services. Santa Fe is also looking at this. That seems to indicate we need more services than what we have.
Absolutely. Absolutely. And in working in collaboration with the county and the city, in discussions, they have said that this money has been earmarked for behavioral health services, but they're having difficulty finding organizations that can fully encompass the needs of the community. And so they're looking towards non-traditional methods, such as peer support, as the Healthcare for the Homeless, the St. Martin's Hospitality Center, who can do a more street-level bureaucracy, kind of a street-level advocacy for the individuals. But that's the problem, is you're going from clinicians to primary care to the emergency rooms, where a lot of people who are in crisis need of services are going to access any type of service to get prescription medications, to get housing, to get basic needs met. And so with this tax money, they're looking to other opportunities, other organizations that can provide not only for the basic needs, but also the behavioral health, and to cover the parity that's happening with the primary care providers and bringing that across to behavioral health services.
The Mental Health America report that HSD has referenced does note one survey doesn't include homeless people, if they aren't in shelters, doesn't include those incarcerated or in hospitals. Are we getting the kind of data that we need to improve mental health in New Mexico? Like, what don't we know? What do we need to know?
I can see, definitely coming from the social work field, how research really does develop the programs that we implement. And there are endeavors right now going on through the state that are reaching out to individuals, anybody who's accessed behavioral health services within a year time frame. And so peer organizations such as where I'm the co-director, the Albuquerque Center for Hope and Recovery, we're contracted through the state of New Mexico, through BHSD, to reach out to anyone who's received at least one behavioral health service within New Mexico for the managed care organizations, so that we're reaching out to those who may not have a traditional means of communication, who may have language barriers, who may have various barriers, rural areas, who aren't being able to access the services or at least go and report on their lack of access. And so things like this the consumer satisfaction survey are reaching out to those individuals to find out numbers, because it is hard when those that are incarcerated, those that are homeless, are not represented overall.
Right. Maggie, a needs survey that was done by UNM's Division of Community Behavioral Health indicates the number of primary care providers has increased in the state, which is good. The number of psychiatrists has decreased. What are you hearing from your members about who provides behavioral health services right now? Where are the gaps?
The shortage in the overall workforce, which includes psychiatrists, but also mental health counselors, social workers on all levels, is dramatic. The shortage in New Mexico is dramatic. Part of it was really exacerbated by the implementation of the Centennial Care Model, which moved all of care coordination, formerly known as case management, over to the managed care organizations, the insurance companies, who paid significantly more than the nonprofits where people were working before, and pretty much gutted the workforce. So we're having, my members, the members that I represent with the New Mexico Behavioral Health Association, are having a very difficult time finding people that are qualified and are willing to work for the salaries that we're nonprofits, for the most part, are able to provide. There are also major issues with getting master's level students out of graduate school through their independent licensure. So we need major help in being able to, hopefully from the reimbursement mechanisms, be able to pay for some supervision of our master's level providers, increasing the rates.
And is that trouble getting the master's level, what is the problem getting them through the master's level? They need mentoring?
They need postgraduate supervision by a qualified licensed independent practitioner. So an agency may have someone, for example, who can provide supervision of the staff but may not be qualified according to the state licensing boards, may not be qualified to provide the independent licensure counseling. All of that ties to reimbursement that the agency gets or doesn't get. So an executive director can't hire a counselor, a therapist who is qualified legally to provide a service and get reimbursed for that until they've gone through this other process, which is about a 2-year process.
How did the shakeup with 15 behavioral health providers in 2013 affect providers and service?
It was devastating in several ways. One, with respect to clients, and we've talked about the clients that are lost. We don't know what happened to them. I think everyone knows that a number of Arizona companies came in, and then 4 of them subsequently left. And all of the associations or organizations that took over for those departing are members of our association. And they couldn't get clear records of who was a client, who wasn't a client, where were they were. There were many. I remember a hearing in Las Cruces where there was this huge argument about how many clients were there. The real problem with that is that those are people who rely on, who are vulnerable, who are fragile, and who rely on continuity of resource and continuity of contact. So anecdotally, what we have heard from many clients around the state is they're not going back because they get a call from a new case manager who says, I'm your case coordinator, and they're thinking, well, who are you and what are you doing?
How long are you going to be here?
Exactly. So I think that's a major issue. And then the other issue that I don't think we've really recognized is that we lost some really significant forces in providing quality behavioral care. The number of executive directors and leaders in the field that had been championing the development of programs and care for many years in New Mexico were wiped out.
I want to go to Natalie. You are a provider, and you specialize on issues of trauma. Talk about the levels of trauma in New Mexico and the impact when it's not discussed or addressed. We've heard about some of these people who lost their providers.
Right. Right. I think it operates on numerous levels. I think there's the global vision of there being historical traumas which are impacting access to care, impacting how families and generational issues are being passed on, addiction issues. But then there's also...
Which we have many in New Mexico.
Which we do have very many. And that, generally speaking, goes unaddressed. I mean, we all know that there's that history there, but in terms of it being a regular piece of the conversation or about how we're going to be addressing it, there's not as much as I'd like to see personally.
There were several bills introduced. Maggie McCowan helped with one of those, and I think you introduced Senator Ortiz-Pino, that would have given providers more of a role in the planning and management process of the state's behavioral health system. There was another one that had to do with the managed care model and taking behavioral health out of it. Why are these important? You have to be fairly quick, and why didn't they succeed?
And the other one was the one that would give people who've been accused of Medicaid fraud, agencies, providers, an opportunity to have grievances and due process. And all of those failed, and the governor opposed all of them, and I think she's just very defensive around this whole issue of behavioral health. So none of those got through. There's not a good reason why they didn't get through. They all should have gotten through, I think, but...
Do you feel these changes would make a difference?
Oh, absolutely. Certainly the due process one would. I mean, who in their right mind right now, except for the current company excluded, would want to be a provider under the when you know some honest billing error can lead you to being found guilty of fraud and or accused of not fraud. Nobody was found guilty, but accused of fraud and lose your contract.
Could there not be a conflict of interest to have providers involved in the process of talking about how you create a behavioral health system? Yeah,
well, I think we need to draw on their expertise, but you balance it out. And we had that whole discussion during the hearings on the bill of how you deal with the potential for conflict. First of all, the individual provider can simply identify the fact that, well, this is an issue that would impact my agency or my work at that agency, and recuse themselves, much as a legislator would do now. But for the most part, you're talking about system issues and policies that that don't affect one agency or one individual, that really are or
So you
broader.
feel, despite what we're hearing from the Human Services Department, that Centennial Care is working, we're getting more services to more people, this isn't what you guys are hearing?
No, and let me just interject that Centennial Care is up for renewal, and so they're
Oh, it is.
redrafting the waiver proposal, and I'm hoping that they make some real improvements in it. That'll be due
The
next year.
concept paper has been posted on the HSD website.
About Centennial Care?
Yes, the concept paper that is, as I understand it, is prior to resubmitting the waiver, but is the result of many public hearings over the last 6 months. That's just been posted in the last day or so, and there are more public hearings on that. So hopefully, I haven't looked at it in depth,
Okay.
but we're hoping that there'll be some things that we recommended.
Thank you all for coming and talking about this. We'll have a link to the statement we got from the Human Services Department on our website about this, and we'll have a link to the draft on the Centennial Care revamp. Thank you so much.
Thank you.
Thank you.
Thanks, Megan.
Thanks.